I mean, he's not wrong. If the child is 99 pounds, or a small adult is 99 pounds, and eats a pound of bacon, they are now 1% bacon.
I guess so.
You know?
Yeah.
I don't know why it matters, but it's true.
Sure.
So, yeah. You know, a pound of bacon's not that much. Just an interesting fact. So go ahead. Anyway, let's start.
Hey guys, welcome to the Sights and Sirens Back to Basics podcast. This is a podcast where my brother, an ER physician, and I, a firefighter paramedic RN, talk about what are sometimes considered to be complicated medical topics. We break them back down to the basics, make them simple and digestible for you, our listeners.
Yep. Love it. Awesome.
Cool.
So you want
today,
to tell...
instead of doing a sponsor today, we're always sponsoring ourselves. We have a prep program. It's for NREMT. It's great. You should check it out. You can go to sightsandsirens.com and check that out at any time. We have a great following with that. Been having a lot of fun with it. Helped a lot of people pass their NREMT, whether it's for paramedic, EMT, or advanced. And that's kind of what we do. That's what we specialize in. And we got some big things coming down the line with that, which is exciting. Instead of doing kind of a sponsorship, I want to give a couple shout outs. One is we have some people email in with questions and things like that. A couple people have been asking me specifically. They hear that I'm a paramedic and I'm an RN, so they want to know like how I did that, the bridge program. So just so you guys know, there is an online college called Excelsior. It is out in New York. That's what I use to bridge to RN, and I do a work as an RN and a paramedic. So there has been some interest in a little bit of our background, Chris. I don't know if you know this, but it's just like maybe doing a podcast about talking about our backgrounds and things like that, talking about each other. That could be fun. There's also some interest, and this was sent in by Garrett, by the way. Thank you, Garrett, for these suggestions. There's also some suggestions about possibly doing a podcast in the future about just like a Q&A where maybe we just read some questions from our listeners and we can just answer those. I think that's a great idea. What we need, though, is questions. So if you guys wouldn't mind sending some questions to training@sightsandsirens.com, that's where I want you guys to send them. We will do a podcast soon and answering your kind of common medical questions. We'll try to get, 20 of them or so. And
ask us anything.
Ask us anything.
Anything.
Because we can choose which ones we answer when we get them.
And we will only choose ones that we have answers for.
Exactly.
Honestly, that'd be great. So send in your questions.
I think that'd be fun.
Again, training@sightsandsirens.com.
We'll have it come up here. And just so you know, it is, what date is it in the future when we air this? Well, it's tomorrow. Podcast time is weird. So it's the 24th.
24th. This is going to air tomorrow, 24th of May.
In 2021, in case you are listening in the far future. If you are in the far future, let us know a couple things. Is COVID over? Do I still have to wear a mask? Am I okay? Did I get the job? Did they fire me? What does the chief want to talk about tomorrow?
Right.
Those are some things that we'd love you to let me know about.
Yeah.
Anyway, send those in if it's within, the next couple weeks here, and we'll try to do something maybe at the end of this month where we do a Q&A or something like that.
Cool.
I think that'd be fun.
Absolutely.
The other thing I want to give a shout out to Luigi. Luigi is a guy that I've been working with in our programs. I know he's listening right now. Luigi, I just wanted to say, continue up the good work. He is busting his butt. He's down with Miami Rescue right now, studying for his paramedic, kicking butt out in the field, studying every day very hard. But he's got family, he's got work, he's got all kinds of things going for him. And I know he's a busy guy, but he is really working hard, and he's going to take this paramedic test on, and we are going to nail it together. All right, Luigi, so just a little encouragement for you.
Love it.
I'm your biggest fan.
Cool.
Love you, man.
Cool.
All
awesome.
Right. Why don't you introduce our topic, Chris?
All right, so today we want to talk about thyroid. We want to talk about the thyroid and the common thyroid disorders that you're going to see not only in the field, but also on the exam. The thyroid is sometimes confusing. It is for me.
It was super. And when I took my national registry, I was like, why am I wasting time with thyroid stuff? Like, this doesn't even, I never even... Like, this seems like too complicated.
It doesn't seem like an emergency problem necessarily.
And you get questions on it. Like, you get questions on Graves' disease and Hashimoto's, and like and you think this is complicated things. I looked the other night just for some research. In the paramedic textbook, it's like 3 paragraphs talking about the thyroid and like what it does. Like, anatomy and physiology, it's important, but talking about like conditions that we have to deal with, it's pretty simple.
Yeah.
Too much or too little. Right?
Too much or too little, but it's hard to differentiate the different diseases. Like, we can talk about what it looks like to have high thyroid levels, and we can talk about what it looks like to have low thyroid levels. So hyperthyroidism, hypothyroidism. But then we throw all these names out there like Graves' disease, Hashimoto. Well, which one's which? Is that low? Is that high? Is it both? Does it and it does sometimes like get kind of confusing that way. So we want to just break it down today, super simple. What does the thyroid do? what are the kind of diseases we're going to run into, what signs and symptoms are we looking for in the field, and then really when it comes to management of thyroid, and there's not many, and there are other things like Thyroid Storm and these different like acute things that can happen with thyroid disorders. But for the most part, this is a chronic, hyper
there's not a whole lot
hypo.
of thyroid emergencies, but we need to be able to spot them out.
Yeah, but we need to understand that when we have a lot of patients have thyroid disorders, what does that mean for them? Because that can affect other things. So again, we're going to kind of get into the pathophysiology behind some of this stuff, some of the anatomy maybe, kind of just briefly talk that. The management is going to be pretty simple, again, because we're not really talking about like necessarily emergent issues that show up all the time with thyroid disorders, but we need to have an understanding of all this.
So it's a funny story. The reason why I picked this topic was because a couple weeks ago I was on a call with a young woman who had she had a hypothyroid, right? So she had low thyroid hormone that her thyroid created. We're going to get into it in a second. But then basically she was having signs and symptoms of hyperthyroidism.
Okay.
And we were like trying to figure out like what. So me having just a little bit more, interest in the thyroid and knowing a little bit more about that than maybe my partner did, I was kind of looking at, okay, I see that you take levothyroxine. So you take a supplement for your thyroid and recently that medication just got increased.
See, there you go. So
now I'm looking for signs and symptoms of hyperthyroidism, specifically Thyroid Storm, which is the big, scary, bad thing that can happen. And I'm giving my report to the nurse, and she wasn't having a thyroid storm, but she was having hyperthyroid issues, Sure. And I'm like, you know what? Like, I'm not seeing any, like, excessive sweating or anything like that. Like, I don't see any storm symptoms. There hasn't been any symptoms. And I keep saying that. And the nurse is like, yeah. And my buddy pulls me aside afterwards. He's like, what the heck are you talking about a storm? He's like, the weather's fine today. Like, I just don't understand. Like, what do you...
It's
and I was like,
degrees.
no, like Thyroid Storm, and kind of explaining. He's like, I didn't know that. I didn't know that. And a lot of medics and EMTs don't know this stuff because it is just kind of one of those niche things that, you might have a test question that talks about it. And it is an important thing to know, but, it's not all that common. The conditions are very common, but knowing what to do when they get into extremes isn't.
And it's funny too, because like I've even noticed this because for whatever reason, and this is not because we were doing this today. I didn't even really know we were doing this topic until like recently. But for whatever reason, I was
not
studying.
Committed.
What's that?
Not committed.
Not committed. we for whatever reason, for some other, I don't know if it was for some continuing education I was doing, but I was doing Thyroid Storm. I was reading up on Thyroid Storm, or maybe it was a lecture. I don't remember. But anyway, I too was reading up on this recently, and then I'm working clinically in the ER, and I'm seeing all these patients coming in, and I'm like, I guess I should look for I should check a thyroid level. I should check a thyroid, because all of a sudden you start if you don't think about it, you never find it, right? We've said that before. If you never think about a diagnosis, you're never going to diagnose because you didn't think about it. So now I'm starting to think about this more, and I'm like, oh, I'm going to get some thyroid levels here and there, and
it's fun to know that you like kind of learn to do your job as you go. And sometimes based on your interests, you remember how to ER.
Right, exactly.
It makes me feel really safe.
Right. No, but I'm saying that like I don't always have the answer as an ER doctor. My job is to rule out the emergent things and then get them somewhere else. So this just gives I've been noticing some cases where I'm like, hey, I guess this could maybe I could get an answer if I checked some thyroid and things like that.
Well, we talk about this all the time. This is what separates basic providers, cookbook providers with experts in the field, right? Is when you take that knowledge that you learn from something like this, or you learn from the outside, and then you apply it to your practice, right? You know how to do your practice. You know how to stabilize a patient. You know how to resuscitate them. But now with a little bit of extra knowledge, we can kind of see the bigger picture and go one step further, which is cool.
Yeah, exactly. So where are we starting?
So let's first talk about just the thyroid in general.
Sure.
Where's it located? What's its function? And we'll go from there. Okay. So where's the thyroid located?
So the thyroid located in the neck.
Point to it.
In the front of the neck.
For our viewers.
Right here.
Can we get a good shot of that?
It might be a little bit lower.
Okay.
But
and it is shaped like
a butterfly.
Yeah. I didn't think you were actually going to get that. Yeah. It is shaped like a butterfly.
It's like
right?
shaped like a butterfly.
So what the thyroid does is it secretes hormones. It's a
thyroid hormone.
Yep. It is a
exocrine gland.
Thank you. Yeah.
Yes.
It gets rid of, or it excretes hormones, right? It's an
nailing
gland.
It right now.
Yes. And it excretes specifically 2 hormones.
Right.
So one is called
T3 and one is T4.
Yeah. So T4 is called thyroxine.
Mm-hmm.
And then T3 is called, and I'm going to have to look at this piece of paper because I don't know this by heart, triiodothyronine.
I mean, probably something close to that.
But here's the deal. Here's what you need to know, okay?
T3, T4.
Thyroxine is T4, and it's called T4 because there are 4 different iodine atoms in that substance, like in that molecule, okay? And then what T4 does is it becomes T3, and T3 is what's used in our body. All right?
The active form of
It's the active
thyroid
form,
hormone.
and that's 3 different types of iodine. So when we talk about iodine stuff later, you're going to understand why low iodine levels or iodine deficiencies or iodine issues can affect the thyroid, because the thyroid's all about iodine. Okay, so and you would get that based on your diet. You're going to get iodine from certain foods. So T4 metabolize or changes into T3, and T3 is the active form of thyroid hormone. So what is the function of this T3? What does T3 do? Well, it works on the metabolism of the body. And when I say metabolism, what am I really referring to?
So when we talk about metabolism, we talk about how the body functions, right? The cellular function is metabolism. So breaking down glucose to make energy, taking the building blocks of the body to build structures and things like that. This is what our metabolism is. And our metabolism can be fast or it can be slow.
Yeah. So metabolism is basically just the speed at which our body is breaking things down, building them, or carrying out the cell's functions, right? Mm-hmm. So T3 becomes incredibly important because the thyroid gland becomes incredibly important because it's going to regulate the speed of our metabolism, whether it's slow or fast, depending on how much T3 it releases. So T3 will amp up metabolism. Right. It will speed it up. So the lack of T3, we start to have low metabolism-like symptoms, hypothyroidism, and that's where we're going to see things like get fat and weird things start happening that would be involved
slowing
with
of things
slow
down,
metabolism, right? And then if we have excess T3, too much, now we're going to be amped up. We're going to have, our skin's going to be hot. We're going to be, responsive to heat more. We're going to lose hair.
Our heart rate might be higher, all this kind of stuff. Yeah,
tachycardia, kind of like. So I think we get mixed up a lot of times because this isn't the adrenal gland. We're not talking about adrenaline. We tend to, in EMS especially, you talk about adrenaline, beta agonists, and we kind of talk about fight or flight versus rest and digest. This is a little different because we're talking about like systemic metabolism in general.
Sure.
But that's how it works. So the thyroid gland is responsible for your metabolism by using T3 to amp your metabolism up or limit T3 to slow your metabolism down. Mm-hmm. 2 big issues that we're going to see: hypothyroidism, not enough T3, not enough thyroid hormone, or hyperthyroidism, too much.
Right.
So let's talk about kind of what happens when we bump into hypothyroidism.
Well, really quick, let me throw in 2 other structures that you should just be aware of in relation to the thyroid gland.
Yeah.
So the thyroid gland is stimulated by the pituitary gland.
Right.
So the pituitary gland releases thyroid stimulating hormone, TSH, which goes to the thyroid and stimulates it to make more of this T4 and then T3 and T3, that sort of thing, right? The other gland that's important to understand is the parathyroid gland. And we're not going to jump too much into parathyroid issues today, but I want you to be aware of it because I have seen this kind of stuff come up on the exam, and it's good to know. The parathyroid gland is essentially 4 little, almost like circular glands that sit on the back part of that butterfly wings, like as it wraps around, okay? Those release a chemical called calcitonin, which regulates and has an effect on calcium levels. So if someone has their thyroid taken out or their thyroid, partially removed, during these surgeries, they're very careful not to mess with the parathyroid glands. They have to identify those because if you have issues with the whole thyroid, including the parathyroid, then you're going to have calcium issues as well. Okay. So just something to be aware of.
It kind of works. None of these systems work independently necessarily, right? So they work together. And the pituitary gland is especially important because we're going to talk about kind of how you can end up with hypo and hyper, and some of that is what's going on with your pituitary gland, because is it stimulating the thyroid if your pituitary gland is taken off and it's dumping a bunch of thyroid stimulating hormone, well, guess what? Your thyroid's going to take off too.
Yeah,
right?
Yeah, exactly.
So if we had hypothyroidism, what are some symptoms that we would see? What are some of these slow symptoms?
Sure. So again, I like to generalize these things because I think for the most part, generalization is okay here. So hypothyroidism, we talk about metabolism. It's a slowing down of metabolism, right? So what kind of things happen? So you have slowing down of activity, right? So maybe more fatigue and weight gain. They have
you're sleepy.
You're sleepy. You have a hard time concentrating. You have real dry skin. And the way we think dry skin is because again, when you're active and going, the way I remember is when you're active and going, you're sweating. Well, you're not sweating, right? Because you're just everything's slowed down. So you have dry, coarse skin. your temperature gets, your temperature almost decreased too. So you get kind of like, you're like colder.
And then if you're exposed to cold, you can't tolerate that cold.
Yeah, cold.
Much,
That's what we call like cold intolerance
or
heat intolerance. Like the body can't handle that kind of thing. Constipation,
swelling.
Yeah, these kind of like.
Then you have like bradycardic effects. Your heart will actually slow down.
Decreased heart rate and that sort of thing. So again, so it's just kind of this generalization of just like slowing down of the different bodily functions, right?
Right. So hypothyroid, low, slow, fat. Like for those of you taking the exam, like some of the big things to kind of catch on are like that tiredness and weakness. That gaining weight gain is always going to be a hypothyroid thing. And so abnormal skin sensations can happen because of that dryness and because of that slow metabolism.
Right.
All right.
So there's a couple things that can cause that, right?
Right.
Let's quickly, before we jump into hyperthyroidism, let's talk about what can cause that hypothyroidism. And we already kind of mentioned it, right? So it's either going to be that the pituitary gland isn't stimulating the thyroid to do anything.
Right. So if you have a pituitary gland issue, there you go.
Right. So it's not going to, that's one of them. It's going to be that the thyroid gland itself isn't releasing T4 or T3, right? Or we don't have enough iodine. Because if we don't have enough iodine, we can't make that T3 or T4 hormone anyway. So it doesn't really matter if it's being stimulated or trying to release anything. There's no hormone to be released. Right. So those are the main mechanisms.
There's one more that I want to mention. Yeah. So we have two autoimmune disorders that we're going to talk about that are involved in both. Well, one's in hyperthyroidism, one's in hypo. So our hypothyroidism immune disorder that we bump into is called Hashimoto's syndrome. Or sometimes called Hashimoto's thyroiditis.
Right.
Okay. So this is basically where, because of a low, so this is what confuses people, is the thyroid gland can swell and you get something called a goiter. You can see this actually in hypothyroidism and in hyperthyroidism.
Sure.
In Hashimoto's thyroiditis, what happens is because of the lack or the burn up, the use of thyroid hormone, we have a thyroid issue, it's low. The pituitary gland starts releasing increased amounts of thyroid stimulating hormone, and even though it's not creating the thyroid hormone in the thyroid will swell because it's overtaxed.
Sure.
Okay. In hyperthyroidism, we have a goiter because there's too much thyroid hormone, right? And it swells.
So you can get a goiter in both.
Yeah. So don't let the goiter throw you off. Okay.
Right.
Because I thought kind of like it was like goiter means this. It can technically mean either.
Sure.
Okay. So
and Hashimoto's thyroiditis, so thyroid itis, like that's
swelling,
cellulitis and diverticulitis. That's inflammation, right? It's inflammation of the thyroid gland. So in this case, Hashimoto's thyroiditis is that autoimmune. Essentially, the body is attacking the thyroid gland itself. So if it attacks the thyroid gland can't release anything. So you get hypothyroidism. And you can get a goiter and swelling because, again, there's inflammation there. Like I said, it's still trying to be stimulated, but it can't release, so you can get that inflammation. So
So iodine issues, pituitary gland issues, because it's not producing enough stimulating hormone, thyroid issues itself, and
now again, Hashimoto's thyroiditis is a specific autoimmune disease that can cause hypothyroidism. There are other things like low iodine levels, or actually
or removal of the thyroid.
Right, or you removed it because
if we took
it was
your thyroid out.
Right,
guess what? You're not producing thyroid hormone, so now you have lack of thyroid. So what are we going to do about that? Well, long-term treatment for hypothyroidism is we're going to give you thyroid hormone.
Right.
Typically with like
levothyroxine.
Levothyroxine is the common medication that's given. But here's the issue. Whenever we give a medication, we have to worry about the opposite effect of what we're trying to go for, right? We have hypothyroidism, so we're giving thyroid hormone. In my case, what I was talking about with my buddy a couple weeks ago, what if we give too much of that thyroid hormone? Now we're getting, even though they have a history of hypothyroidism, now we're getting hyperthyroidism because we gave them too much, right? And this is where kind of it becomes very nuanced with the pharmacology. We have to be careful as as a medical field, the providers, the true providers like you, when you prescribe this stuff, you have to be very careful about kind of measuring the amount and watching that over time, because you don't want them to go to one extreme or the other.
Exactly.
So just keep that in mind. You might have a patient like I did that has a hypothyroid. I have a low thyroid. That's what she says. I got a low thyroid. Well, then I know you're taking thyroid hormone, and if you're taking too much, guess what? You're having high thyroid symptoms.
You're at risk of hyperthyroidism.
That's what I think is like, it's nuanced, but it's interesting. It gets me excited.
And if you have a history of hyperthyroidism and they decide that they're going to treat your hyperthyroidism with taking your thyroid out, now your history of hyperthyroidism, now you have essentially a hypothyroid state, and then you're put on a thyroid hormone, and you're at risk of hyperthyroidism again if we over medicate.
It's all about that kind of understanding the chain of events that happens when we treat.
There's one other thing I want to throw in here, and because like we talk about, especially in EMS, we're talking about extremes. We're usually dealing with extremes. All right, we're going to talk about what the extreme. You kind of already talked about and we're going to get into it more. The thyroid storm being when you have hyperthyroidism. The extreme of that would be thyroid storm, a life-threatening condition. The life-threatening condition for hypothyroidism is myxedema coma. It's called myxedema coma, and essentially the thyroid is so low that things have slowed down so much that these patients go into a coma.
So as
and
an emergency provider, that's what we're worried about. Right? Like low thyroid, what are you going to do? Hey, I've been gaining weight.
Right.
Like, okay, like...
Right.
I mean, that's not something an
Call
emergency responder. But if we run into someone who has neurological deficits and it appears that they're in a comatose state, and we know they have a history of hypothyroidism, or a history of hyperthyroidism and a recent thyroid surgery where it was taken out, right? We know that can cause this myxedema coma, and now we can get the ball rolling with communication and know what's going on, right? Is it going to change our emergency treatment? Probably not, right? We're still going to intubate. We're still going to, do what we can to stimulate the body,
stabilize
it, resuscitate it, but we can get the thought process and the doctors going faster if we can identify this stuff.
And again, it's one of those things where if you don't think about it, you won't see it. So you got a patient who's, unresponsive, fatigued, and the family says, oh yeah, like she's been putting a lot of weight on, she's becoming more depressed and fatigued and all these kind of things for the last couple of days. And then you get your vital signs and the heart rate's like 30. Well, hey, now we see why all these pieces might come together and say, oh, this might be a super low thyroid issue. And then we can now relay that. I can check that right away when they come in. Bam, we solve the problem and save someone here. The other thing too, that like what can cause low thyroid, it's not just taking it out. It's not just that you have pituitary issues or iodine issues. You can also see damage to the thyroid from surgery, like we said. You can see damage to the thyroid from radiation treatments. So if you have like a laryngeal cancer or a throat cancer and you're getting radiation treatments to the neck, that can damage the thyroid, lead to hypothyroidism. And there are some drugs too that are toxic to the thyroid gland if we're not careful, and those can damage it as well. So anything that damages the thyroid can lead to hypothyroidism. And again, the treatment then would be giving that person a medication like levothyroxine, which would replace that thyroid hormone that they don't have.
Thyroid supplement, right?
Yeah, exactly.
Cool. So on the other side of this is hyperthyroidism.
Right.
So signs and symptoms of hyperthyroidism are going to be signs and symptoms of too high of a metabolism. So now we're looking at kind of the opposite. We're not looking at weight gain. We're looking at weight loss, right?
Right.
So skinny, losing weight. We're not looking at cold. We're looking at they're amped up, they're hot, right? So they're going to be hot, and they're also not attractive, but just warm. And they're also going to have.
I don't discriminate.
They're going to have heat intolerance, right? So when they're exposed to heat, because they're already warm, they're going to have that intolerance.
Sure.
They're going to actually lose hair, and you're going to see thickness of areas in their skin, like clumps of areas where you have like thick skin areas,
sure.
because you amped up metabolism of those. You're producing more skin cells and building that up. Increased appetite is really normal, right? Because you're hungry. You
feed that metabolism.
You got to feed the metabolism. Lean, thin.
They're also going to have, they're going to have increased heart rate. They're going to have sweating. They can even experience like irritability and restlessness and like difficult, because like I said, everything is overstimulated. Metabolism has ramped up here and that sort of thing.
Now, the extreme of hyperthyroidism is something that we call the thyroid storm. Chris already mentioned it, and I mentioned it in my case. But thyroid storm basically can be activated by anything that amps these things up. So if I take someone who has hyperthyroidism and they're really warm, and then I increase the heat, right, and I expose them to a bunch of heat, it can spike their symptoms into that thyroid storm symptoms.
And another common reason we see people, thyroid storm is rare, but like myxedema coma is on the other side of it. But thyroid storm, another reason that we have to be aware of it is that, especially from a medication standpoint. So if you're someone who has very high thyroid levels, and then I give you some kind of stimulant, or I give you something, like that, that can really bring on that
increases metabolism even more.
Right.
And now we have
extreme
issues.
Fight or flight too. If any real stress to the body, You know what I mean? Like any trauma or stress to the body can throw these people, if their thyroid levels are high enough to be at risk of thyroid storm, can throw people into that thyroid storm type of state.
Yeah. So to take you back to the case that I had, this woman had just started taking more levothyroxine because she has a hypothyroid. So now she's getting more thyroid hormone, and she's starting to have hyperthyroid symptoms. Her heart rate was very high. She had high blood pressure and a splitting headache.
Okay.
So what did I do? Well, I'm concerned about this spiking into a storm state or something like that, right? That's what I'm concerned about. Well, I turned the lights off in the ambulance, in the back of the ambulance. Turned the lights off, kept her calm, tried to keep her cool.
Sure.
Crank the AC up. There's little things we can do to change the environment to stop you from that fight or flight, that stimulus response, right? I'm so hot. Okay, well, we're here's an ice pack for your head. Try to ease the pain a little bit, keep you cool. Let's lower stimulus. We're not going to turn the TV up and start yelling at them or panic them in any way, right? Because it's going to slow that metabolism down and prevent them from going into that kind of spiked thyroid storm state.
Definitely.
All right.
Yeah.
So what causes hyperthyroidism? A common issue, the most common reason for hyperthyroidism is another autoimmune disorder called Graves' disease. And this is basically just an autoimmune disorder that causes an overactive thyroid.
Sure.
And again, autoimmune is always kind of the body attacking its own cells and doing things like that. This interrupts function in a way that causes an increase in thyroid secretion. All right. That is the most common cause. It's called Graves' disease. The other side of that, the autoimmune for hypothyroidism, was that Hashimoto's thyroiditis.
And again, this is where it's going to get a little complicated, but Hashimoto's thyroiditis is inflammation of the thyroid. So in the very beginning stages of Hashimoto's thyroiditis, you can get hyperthyroidism because it's overstimulated, and then it's so overstimulated that it basically almost like doesn't work anymore. And then we see, so like I said, I don't want to complicate it for people, but again, you can just get inflammation of the thyroid gland that stimulates it, and then if it's overstimulated for a period of time, now it loses its ability, and now you've got hypothyroidism. So just being aware of these two things. But again, for the most part, if you want to do some generalization, Hashimoto's thyroiditis leads to hypothyroidism. Graves' disease leads to hyperthyroidism.
And if we're talking National Registry or medic school tests or EMT school tests, just relate Hashimoto's to hypo and Graves' to hyper. They're not going to give you this. Well, technically in the acute phase, they're not. I'm telling you, we are educators.
Right.
They are not going to do that. I can guarantee it. It's not going to get that level of complication. They don't even do that on the NCLEX and things like that. It's very much Hashimoto's is related to hypo, Graves is related to hyper. Other causes of hyperthyroidism, thyroiditis in general. You have inflammation or infection of the area of the thyroid, and now it's spiking, that swelling.
And you can have you can just be someone who has an overactive thyroid gland compared to normal people. You don't necessarily have an autoimmune Graves' disease, right?
Sure.
Like, again, we're talking about two autoimmune diseases within these categories. There's lots of other reasons, right?
Yeah.
So you can have, like I said, just an overactive thyroid, or like you said, your patient, over medication. They have too much medication of thyroid hormone and that sort of thing. So
exactly. So how we treat this long-term wise, emergency treatment, again, is just going to be, stabilization, resuscitation. Like I said, you can control that environment, try to cool them down, calm them down to prevent something like storm happening. But we're going to kind of treat symptoms as they come. Long-term treatment of this, we can use Methylmazol, which is basically a medication that decreases... It destroys thyroid hormone, doesn't it?
So there's a couple different, just to keep it simple, back to basics, there's a couple simple medications we can give for patients with hyperthyroidism. One would be to interrupt the ability of iodine to bind, right? And I'm not going to name them because it's just not worth it. Or one that actually blocks the action of T3 or prevents it from, keeps everything T4 so it can't become T3. There's different medications that do different things like that.
So we can give medications. We can also radiate the area with radioactive iodine. So we can give, just like radiation for cancer treatment, we can kill basically, especially with like Graves' disease. So we have like an autoimmune disorder.
Right.
So we can kill those bad cells basically with radioactive iodine. And then iodine, because iodine's going to get to the thyroid gland so quickly, right? We do iodine, we radiate it, and then iodine's going to go to the thyroid gland because that's how they make T3 and T4. And then that iodine is, because it's radiated, is going to kill that area and kind of calm it the heck down. And then the last thing, in extreme cases, we might just remove that thyroid. Yeah. And why do we do that? Because we can give them supplemental thyroid hormone in the form of
And that's very
levothyroxine.
common. Like I said, if you got someone who's struggling with, hyperthyroidism, and it's not the medications for hyperthyroidism are sometimes difficult to regulate. So it's very common for someone to have their thyroid removed then in that case.
Right.
So. Right. But that's pretty much it. I mean, like I said, so a quick summary, taking it back to basics. Like I said, thyroid gland, hopefully we broke it down in a way that has simplified it for you, right? So it releases T3 and T4. T3 is that active part that actually increases metabolism. So if we have too much thyroid, we have hyperthyroidism. We're going to see a ramping up of metabolism with those symptoms and signs that we talked about. Things that can cause that include an autoimmune disease called Graves' disease, which increases an autoimmune component. And there's other things like overactive thyroid and stuff like that, right? On the other side of that is that if the gland is not producing enough T3 or T4 or is being blocked or inflamed, we get hypothyroidism. So we get a slowing down of metabolism, those signs and symptoms we talked about with hypothyroidism, like weight gain, etc. The extremes of these two things are going to be myxedema coma for hypothyroidism, where everything is slowed down so much that they are basically in a coma, or for hyperthyroidism, thyroid storm, where things are so stimulated, so amped up that we're now in a life-threatening condition where our temperature's too high, our heart rate's too high. These are the kind of things we're looking for on both sides of that from an emergency standpoint. And then understanding in the middle what can be causes. Is it medication related? Did they have their thyroid out? Do they have one of these autoimmune diseases? Are they on medications? Did they get radiation? Now we can start to see how all these play together to give us either one of these kind of syndromes.
And just remember, the history can actually be telling you the opposite, right? So in my case, I had a patient with a history of hypothyroidism. Well, that means I know what the treatment is for that. We give them thyroid hormone. If we give them too much, we start now seeing symptoms of hyperthyroidism. And that's kind of the nuanced stuff that we want you to be able to catch. But I think that's all we got for today.
Cool, yeah.
Hopefully that cleared some things up for you.
And if you guys have questions on this, because this stuff can sometimes get confusing, please email us. Because if you have the questions, so does everybody else. So we can just address it next time or shoot off some email to our listeners to let you guys know. If anything's ever confusing that we're talking about, if we're not breaking it down exactly how you need us to, hey, let us know, give us some feedback, and we'll take care of it. Training@sightsandsirens.com. We always welcome that feedback. But again, we thank you guys so much for listening. Again, Luigi, good luck to you. We're going to be working alongside you to help you get past this exam. If anybody else needs help with the National Register exam, whether you're an EMT, paramedic, or advanced EMT, we got your back. Check us out at sightsandsirens.com for our prep program, question banks, workbooks, the whole 9 yards, and you get to spend more time with Jason and I, which, I mean, that's just a win. That's just a win no matter what. Yeah.
Every time.
We should just start charging our friends to be our friends.
You don't already?
I don't have any friends.
So, all right, guys, don't forget, email those questions in because we do have a Q&A coming up, and we'd love to tell you more about ourselves if that's something that you guys are interested in. We get some more feedback with that. We appreciate all the questions and comments that you guys have said so far, at least the nice ones.
Yeah, exactly. So, all right, guys, have a good one. We will see you next week for our next episode.
Stay sweet. Hey guys, hope you enjoyed the episode. If you're an EMT or medic student, or an advanced EMT student, or an instructor of those students, we have a program just for you. With Sights and Sirens NREMT prep program, you get video lectures, over 15 hours of really vetted, great content to help you through your program and help you prepare for the test. Check it out at www.sightsandsirens.com.